I would like to welcome you all here. I'm Chris Vanucci, and I work with Alzheimer's Australia New South Wales here in Tweed Heads. I'm a project officer working on sector development and community awareness raising. On behalf of the North Coast New South Wales Medicare Local and Alzheimer's New South Wales, I'd like to welcome you all to our session on understanding younger onset dementia. Firstly, though, I would like to acknowledge the original custodians of the land on which we meet tonight, the Bundjalung people. I would also like to pay my respect to elders past and present, and welcome any Aboriginal people who may be here with us tonight. We wanted to start the evening, however, on a much more personal note, with a short presentation from someone who is actually living with younger onset dementia. We are then very grateful to have with us here tonight Vicki Noonan and her husband Graeme. Vicki is 59. She was diagnosed with vascular dementia in March 2013. Vicki and Graeme are going to share with us a little bit this evening about some of their story to date. So without further ado, I would like to invite Vicki and Graeme, Vicki, up to the podium, and could you please give Vicki a warm welcome.
Good evening, everyone. Firstly, I want to thank Chris for inviting us here tonight to give a little insight into our story. People with dementia often have difficulty expressing how they feel, which I can relate to, but I feel fortunate that I am still able to share with you my experience. I normally wouldn't read from a prepared paper, but my memory's not too good, so I have to, so I apologise for that. I have two beautiful sons, aged 24 and 27, and a wonderful and supportive husband. I worked as a primary school teacher for over 30 years, and I just loved every minute of it. I've always been a perfectionist though, and this always led to a lot of stress. In 2002, I suffered my first stroke, collapsing in the classroom, and it took months to diagnose that it was actually a stroke. I immediately noticed changes in the way I functioned in the classroom. My eyesight was affected and I had trouble doing maths, especially times tables and problem-solving activities. However, I continued teaching until 2006 when I had another two strokes just weeks apart. I was then unable to teach anymore, and I found this absolutely devastating because I loved it so much, and I thought I'd be teaching for at least another 10 years, and I thought I'd be saving money for another 10 years, so it was sort of a bit of a shock. Following my first stroke, I was sent to a neurologist and was treated for depression and anxiety, as I was feeling extremely low at the time because I couldn't do the things that I could always do. This was the first time that I had actually suffered from depression in my life. Things gradually got worse and I was getting lost when I went for a walk. I couldn't find the car at the supermarket ever, and I could no longer handle money, especially small change. So going to have a coffee, I could not count the coins to have a coffee, and I couldn't work out how much change I would get back, so it just wasn't worth me handling any money. As this was going on, I was looking after my 80-year-old mother, whom I adored. I was her only child. I haven't got a dad. And at that time, she couldn't accept that there was anything wrong with me or why I wasn't working anymore. She was becoming increasingly difficult, and I had a breakdown, and I ended up in the Tweed Heads Hospital in the mental health ward. I was tested while in there, and it was found that I may have early onset dementia. However, nothing was really done about this because soon afterwards I found that my mother had late onset dementia, which is why she was acting so tough on me, I think, at the time. That was in 2009, and I was still being treated for depression. I spent the next 2 years caring for her, and she also developed, unfortunately, during this time, a fatal melanoma cancer. This was a particularly tough time for me, especially when she passed away because we were so close. With time on my hands after that, I finally realised all of the things that I wasn't doing anymore. I was cooking less, I wasn't wanting to socialise, I'd become more withdrawn, I lacked confidence, and I was really depressed. Last year, my local GP sent me to the coronal clinic, and here my medication was reviewed and altered. My husband spoke to my psychiatrist at the clinic and mentioned that my memory was getting worse. My psychiatrist suggested I visit the memory clinic within the hospital. This was organised and I spent a half day completing memory tests. And upon not going so well at the test, I was sent to John Flynn Hospital, where I had a CT scan, an MRI and a brain spectrum scan. This was all resulted in me being diagnosed with at least 2 forms of dementia, one being vascular, but the scan showed that the damage had gone global, which, as my doctor explained, meant it had spread all over my brain and was moderate to advanced. It was believed that my earlier strokes had caused some damage, and this led to the build-up of plaque and white matter. On hearing this news, my thoughts went straight to my 2 sons and husband. All I could think about was that they were going to have to one day see me not recognising them, and I felt so sad for them. I honestly didn't think of myself at the time. What I did then was I wrote a letter, a small letter of about 2 pages each, to each of my sons and my husband and my best friend, telling them how I felt about them while I could, because I didn't know if I could tell them how much they meant to me a little bit later on. So I did that and got that out of the way, and I'm really pleased that I did that. Currumbin Clinic and its personnel have been wonderful. My specialist at the clinic put me on Memantine and suggested I try a new supplement from the Netherlands called Souvenade, which has lots of nutrients and minerals in it and is supposed to be helpful for Alzheimer's sufferers. I take it daily and I've been taking this for about 12 months, and I honestly don't know if it's helped, but I'm still taking it because it just might. However, both the tablet and the mixture is quite expensive for us. My own family seemed to accept my diagnosis quite well, although probably didn't let me see their actual feelings. I had been tested to see if my dementia was hereditary, but found it was not. And so I think that allayed some worries for my 2 sons and definitely for myself. Although at the time my younger son asked whether it was appropriate to keep laughing at me, as both of my boys have always taken delight in teasing and laughing at their mum and dad, and this has made our relationship with them so special. Having that humour in my life, I think, has certainly helped me cope with this disease. I decided not to keep my diagnosis from my other family members and close friends, and this has led to a great deal of disappointment for me, as many of these people I haven't heard from or seen since. Some virtually didn't believe me because I looked the same. Maybe if I had a bandage on my head, they might have believed me. I have noticed people avoiding me at the shops so that they don't have to engage in conversation. This is probably not their fault, because we, as a society, I don't think have ever been taught how to talk to people with dementia, whether they're young or old. The fact remains that people with dementia are people and they have the same feelings as everyone else. At present, this is my current situation. I cannot make decisions virtually on anything. I rarely feel hungry, and most days I forget to eat, I forget to have lunch. If it were not for my husband, I would forget to take my medication, even though it's in a Webster pack. My self-confidence has declined noticeably, and I really don't enjoy socialising anymore. And I can tell you that it's very difficult for me to stand up here and do this, but I thought it was really important. My anxiety levels have increased so much, and this gets worse and worse in social situations. A couple of months ago, I had to, my elder son asked could he bring his girlfriend down to stay for the weekend. And I had met her a couple of times before, but she hadn't been to our house. And I am no good with visitors. And he had asked me a week before, and I said, yes, that'd be wonderful. And I spent that whole week shaking uncontrollably with tremors. I couldn't do a thing. I was so worked up about meeting this girlfriend who I'd already met before. And when she came, as lovely as she was, I couldn't do anything. I couldn't set the table. I couldn't clear up anything. I couldn't do anything. All I could do was live through that moment and that weekend. So my son had no idea, I don't think, how bad I was, but I had a whole mouthful of cold sores from it, and I'm still getting over that, and that was 2 months ago. So it was very difficult. So I don't really have people at home anymore as guests. I get confused constantly and have trouble crossing roads, especially roundabouts where everyone's going which way. And sometimes I cross before I remember to look. I was walking about 1 hour a day, but now it takes up to 2 hours. And I don't know why. I don't know whether I get tired now, and I don't know whether it's because I get a bit carried away or get lost, or I don't know. But my psychologist, who I see weekly, and I need to, and she gets me through every week, she keeps telling me to shorten the distance I walk, but I forget. And I only remember when I get to my normal turnaround point that I was supposed to shorten the distance. I also have trouble walking between doorways, misjudging the space, and I always knock my shoulders, and I'm covered from head to toes with bruises, and I run into people when I'm at the shops. I forget to look where I'm going. I forget whether I have cleaned my teeth or gone to the toilet. So I keep cleaning my teeth and go to the toilet all day long. When I can't do anything on the toilet, I realise I've probably just been. That's supposed to be funny, actually, but it does. That's what I do all the time. I keep forgetting I have dementia. But then something happens and it dawns on me that, oh, that's right, I've got dementia. And I grieve all over again, like it's the first time that I've realised that I have dementia, and I feel sorry for my sons all over again. I feel sorry for my husband again. But I have good days and bad days like we all do. I'm really noticing how I forget the end of sentences now, and also how I forget common nouns. So I try to explain things in a roundabout way. I'm finding this frustrating, and I've started getting angry at myself for this, and it's annoying me because I'm not an angry person. However, I do believe it's not all doom and gloom, and thankfully I can still laugh at myself and the silly little things I do. It is okay to forget things, because in the scheme of things, it's no big deal. Often I substitute wrong words for the correct ones. For example, while I was trying to play table tennis with my son the other day, who was up visiting from Melbourne, I said, oh, the ball missed my rabbit, instead of racket, which really should have been bat. But we just rolled around laughing, which is a really good thing to do. Certainly one of the positive things I've found is I've been attending the memory clinic at Currumbin Clinic for about 6 months, 1 day a week, doing the Healthy Minds program. At first I found this confronting because most of the people are a lot older, and they reminded me of my mum and what I'm going to be like. But now I enjoy helping them, whether it's finding their way to the toilet or just picking up their walking stick or handing out papers. I feel it's boosting my confidence a little, and we do brain training games, breathing exercises, art and Tai Chi, and this has helped my balance, which hasn't been good, and I now feel a part of the group, and I really enjoy going. It was also suggested I try Lumosity on the computer, which I've been doing approximately 4 times a week, and I've found this really beneficial. I'm not very good at it, but it's fun, and I really find it has helped. So on reflection, I wish I had been able to follow up on my earlier diagnosis so that I could have been proactive a little bit more about my training my brain a little bit longer. I'm grateful that I've kept in regular contact with my GP and various specialists. I believe that it's imperative for everyone to do so, and that there be continued communication between health professionals about for each person that has dementia. Dementia can present itself in many ways, and people need to realise that it's not just about memory loss. I wish it was.
And actually, Vicki's husband, Graeme, would also just like to say a few words, which I think is very pertinent. So, welcome, Graeme.
I'll keep this fairly brief because Vic's pretty well covered what I wanted to talk about. I just wanted to sort of give you my viewpoint on my take on Vic's condition. Firstly, I'd also like to thank Chris for inviting us here tonight, giving us an opportunity to talk. Also to Lifebridge, who have been really supportive to me. I've got on board with you about 5 or 6 years ago. I came on board as a volunteer with the men's group on the bus, which was really good, and enjoyed it. And along the way, we've got to know each other a lot better. Particularly Wendy, who's been on board with me for all that time. Certainly over the last 18 months, her expertise in dementia has certainly helped us and been instrumental in getting us involved with these programs, the Living with Dementia program, the Early Onset Dementia program, and a few others, and always keeping us updated with what's going on and what's available. As I said, I'm here to give you my side of it, and I want to be completely open and honest with you, because that's what you're here for, that's what you want to hear, and that's what you deserve. As Vicki has said, that this disease is not visual in her condition of being diagnosed as moderate to advanced. It's not a visual, or not noticeable until sort of the later stages. The difficulty that she has and I have with her is because of that. A lot of people have come and gone. Some of the people that we do meet in the street come up to us and make a point of telling her how good she looks and how wonderful she is and how fabulous she is and all this and all that, and which is all very nice, but it's not an external thing, it's an internal, and I can assure you that it is absolutely ripping her apart inside. I've got to put the specs on because I can't read it properly. People don't see it. They don't understand it. They just don't get it. Some don't want to even know about it. Either they're not interested or don't know how to deal with it. This disease has had a massive effect in every possible aspect of Vicki's life, from her own lifestyle right through to simple bodily functions. She's mentioned fatigue, awkwardness, depression, anxiety, lack of sleep, memory loss, lack of confidence, decision making, coordination, motivation, not wanting to cook, socialise, not wanting to shop, or simply talk on the phone. One of the biggest issues that she faces is her driving, and how she is diminishing her driving because she is fully aware of her limitations, and this is a massive ordeal, I believe, with dementia people actually pulling the pin and saying, I'm going to put the keys on the board and that's it, I'm not going to drive anymore. Vicki is realistic to know that she is certainly limited with her reaction time in a car, getting confused with traffic lights, intersections, whatever, and she's quite openly said that she will give it up because she could not live with herself if it came that she was responsible for causing an accident, someone got hurt, it would just absolutely kill her. So she's made the call that she will hang up. Her driving at the moment is just very limited to the local shops and back. Go down the front for a cup of coffee or whatever, but that's it. Pretty much everything after that I do the driving. As I said, this is a disease, one of many around the world, but horrendous diseases, and in my opinion this is right up there with the worst of them, because what it actually does to the body and to the mind, it's pretty tough. Vicki has always been an extremely positive person, very gutsy. I think that's come to the fore tonight when just standing up here giving her speech. She's a fighter. She's faced a lot of adversity in her life from childhood. She's gone through a lot of things, had 2 extremely difficult pregnancies. Dealing with this condition she's got right up till today. It's certainly tough seeing her go through it. It's tough for the boys, but it's even tougher for her. One of the big things I've had to learn over the last 15 months is patience, just how important it is, patience for the carer, or from the carer and people involved, because you've just got to take on board their point of view. Whether you believe them, whether you've got a different point of view, it doesn't really matter. Main thing is, as long as you're there to support, whether they ask the same question over and over, you just got to keep replying as though it's the first time it's been asked, and really just try and keep a lid on your own frustrations, I guess, because it doesn't help in any way if you start to lose it. A couple of positives have come out of this, and we are fortunate in a way that we've got time on our side. So we've been able to put things in place with our legals and finances and information for our boys when the time comes. Unfortunately, so many families don't get that opportunity. So that's been a very important thing for Vic to know, that everything's sort of taken care of in that department, and also for me too. Another thing that's been really good for us is that we actually went out and bought something. No, it was not a Jeep. We bought a little puppy dog, which has just been absolutely wonderful for Vic. Little puppy, we've had it for a month now. It's only 3 months old. It's a little Maltese Shih Tzu. And I was reliably informed the other day of what a Shih Tzu was. They told me that it was a zoo without any animals. Whether you believe that or not is another thing. But it was really important to Vic, because just over 12 months ago, we had her little baby dog that she'd had for 15 years. Pardon me. It was her little baby girl, and unfortunately we had to put her down the day after Vic came out of Currumbin Clinic on her first stint, the very next day. So that was very tough. And it's taken her a long time to get over it, but the time has been right now to get another dog, and we just love her to death. She's just our little baby, and the only thing different with this one is that it doesn't have a dummy, but everything else, we're just going back to childhood. Another important thing that Vicki has insisted on me is that I have my own release time, my chill out time. I'm lucky that I'm still able to chill out, go down and have a couple of beers down the club or the pub, or I like a beer and I like a bet, and she knows that it's really important to me. So I'm very fortunate in that regard, because there's a lot of people with this condition that are just housebound 24/7, especially a lot of older people, and there's an older couple that we're involved with, we've got very fond of, because they remind us of our own parents, I guess. They're in a situation where they're virtually housebound, and he's got the condition, and she can't let him out of her sight, and he won't let her out of his sight. So that's very, very tough on her, because he was the one, the provider of the household. He was the one that did all the driving. He was the one that did all the jobs around the place. He was the one that was the income earner of the family, and then all of a sudden that stopped, and it's all been put on her. And she's battling with that, plus she's not a very healthy woman herself. So we saw them today, and it was very sad for us today to see that. In closing, I just want to say thanks. I know we've gone a little bit over time, Chris, but it was important for us to convey to you our story. Thank you for your attention. If I can just leave you with two significant comments that came out of Vic's speech, which have really sent a message to me, and I hope, hopefully, that when you go away from here tonight, that you'll take this on board. She made two comments. One was that if only it was just my memory, and the second one was I forget I have dementia. Very significant to me, and hopefully you got something out of that. So thanks again. That's it.
Good evening, everybody. My name's Liz Flack, and my role here this evening is to introduce our next guest speaker, Dr. Lana Kossoff. Dr. Kossoff has been an old age psychiatrist since 1993. She's a member of the Faculty of Psychiatry of Old Age of the Royal Australian and New Zealand College of Psychiatrists, the RANZCP. She is currently a visiting medical officer at the Hunter New England Local Health Network, and she also works in private practice in clinical medico-legal psychiatry. She is a Foundation Fellow of the Faculty of Forensic Psychiatry. Dr. Kossoff was previously the Medical Superintendent and Executive Director of Macquarie Hospital, North Ryde, New South Wales. At Macquarie Hospital, she led the hospital in achieving a number of awards. Thank you. For health initiatives undertaken there, including the New South Wales Healthy Hospital Awards. Dr. Kossoff has been providing telepsychiatry services to area health services and nursing homes across New South Wales over the last 12 months. She is currently the chair of the Committee for Professional Practice, RANZCP, and is chairing the College Telepsychiatry Working Group, which has developed a practice manual for the benefit of college fellows who provide telepsychiatry services. Please join me in welcoming Dr. Lana Kossoff.
Good evening, everyone. Thank you for coming, and thank you to Vicki and Graeme. I mean, you've made my talk so much more poignant, because I can talk about the effect on sufferers and carers, but unless you've lived it, nobody really knows what it's like. So that was very, very courageous of you, and I really appreciate you coming. I spoke a year ago at Kingscliff in a similar venue on the differential diagnosis between the different sorts of problems that you can get in the elderly, including delirium, dementia, depression and medication things. This year, the Alzheimer's Association is doing a campaign and a lot of information sharing about younger onset dementia because of the increasing numbers, as you heard from Chris, in regards to how many people have dementia under the age of 65. And that is only the diagnosed ones. I think one of the really difficult problems, as with Vicki, is that it is often misdiagnosed as a psychiatric disorder early on in the piece. This talk, however, is I'm aware of the multidisciplinary nature of the audience, and the talk is probably pitched at doctor level. So some of the stuff about MRI scans and long words like progressive nonfluent aphasia and things like that are going to be a little confusing for some people. So if there is something you don't follow, just put your hand up and I'll stop. Because I think it's important to try and understand younger onset dementia, because it's quite different to your older onset Alzheimer's disease. The other thing is I'm just 3 months post knee replacement, so I won't be able to stand for an hour. So that's why I have the seat here. I've used the Alzheimer's Association has put out a very, very good manual on younger onset dementia, and I've organised for you all to have a copy of that. It's a great reference material, and I've stolen some of the slides from that manual, but then I've added some more of my own, and I've put in some vignettes of patients of mine with all the different sorts of diagnoses so that you can try and understand the differences. We've got lots of types of dementia. In the elderly, about 25% of people have Alzheimer's disease, and then there's the mixed vascular and all the other unusual dementias. It's not like that in the younger onset dementias. You've got many different causes, and sometimes you have two causes, and there's a lot of neurological disorders that I will talk about later that present in that age group, which are things like Huntington's disease and those sorts of things, which also present with dementia symptoms. So they're really quite different, but still Alzheimer's and vascular disease account for 50% of them. If you look at the ones that are not Alzheimer's and vascular disease, we have frontotemporal dementia that we used to call Pick's disease, but we now know that there are many different sorts of pathologies that cause frontotemporal dementia. We have Lewy body dementia, which we have in the elderly, but we also have it in younger people. We have Lewy body dementia with Parkinson's disease or with Huntington's disease. They're not together necessarily, but they've got similar pathological correlates. So they call them the synucleopathies. So they don't deposit amyloid, they deposit tau, which is the two different sorts of proteins. Then we have alcohol related, which is quite common, and also people that are drug addicts such as with benzodiazepines can look like they've got dementia when it's substance abuse and reversible. Then we have some of the neurological disorders, multiple sclerosis and HIV and some of the other ones. And then you've got people with intellectual disability, particularly Down syndrome, have an earlier onset of Alzheimer's or other dementias because of probably the cerebral reserve issue. So we're looking at quite a number of different diagnostic groups. Probably 20 years ago, we always thought that younger onset dementia was always Pick's disease. That's the way I always thought. There was Alzheimer's disease, there was Pick's disease, there was obviously alcohol and all that, and there was vascular dementia. It's not like that anymore. We know a lot more about the area, and we can thank Professor Hodges, who has accepted a visiting scholarship to come to Australia to set up the Frontier Group. It's now called Neuroscience Australia, and he's a world expert on frontotemporal dementia, and we've been referring people to him over these 5 years, and a lot of this new research has come because of the massive effort of the Frontier Group and the government for funding him to come out. So when we're talking about the brain, and we have to go back to some basic neuroanatomy, because depending which part of the brain is affected by the pathological process, it will affect the symptoms that people present with. So we're going to go through this in a couple of slides, but the left side of the brain produces words on the temporal lobe. Problem solving is in the parietal lobes, frontal lobes and parietal lobes. The behavioural control and emotion is at the bottom of the frontal lobes. So this huge lobe, the frontal lobe, has got different sections in it that do different things with behaviours. We've got the temporal lobe that looks at memory and emotions, and further up the word understanding. And we've got vision at the back of the brain, which can still be affected in dementia, but less frequently. And we have numbers and where things sit within each other. So things as you described, like not remembering where the exact part of the street is or the curb, and that's all a parietal lobe function. So the brain is a very, very complex organ. I mean, each one of these sections of the brain all talk to each other with millions and billions of connections, which actually we now know grow and change. So they don't just stay static. You're not just born with the neurons you were born with, and at the age of 18 you start losing them. We now know that if you use them, you can make them grow, and that's why lumosity and things like that happen. But what often happens with dementia, it's not just the lobe that's affected, it's the communication between all the different lobes, and it's those communicating networks that cause some of the symptoms to overlap between different diagnoses. We've got frontal lobe, parietal, occipital, temporal, and the cerebellum. Cerebellum doesn't get involved much with memory, but it does get involved with movement and gait disorders and some balance and coordination. So, frontal lobes. They do the planning and organising and decision making. So if you can't do that, you might have apathy or you might have a disorganised life that we commonly see. They cause the starting and the stopping of the actions, the regulation of social behaviour, so that people lose social cues. They often lose the ability to understand things in a sarcastic sense or in a joking sense. Our frontal lobes do all of that. Working memory, so while memory is in the temporal lobe, the way we manipulate working memory is, I now know what I just said 5 minutes ago and I know what I'm going to say in 5 minutes' time. So it's not that it's laid down in short-term memory, it's what you're doing currently and makes the flow of things happen. I'm sure you've discovered that working memory is one of the most difficult things to live without, because that flow part of things stops working. Speech generation and then insight. That's just the frontal lobe. It's a very large lobe. We've got the parietal lobes, which is for sensation, attention, reading and writing and spatial orientation, so how you get yourself around the place. The occipital lobes are for visual processing. Lewy body dementia causes atrophy in the occipital lobes, so whilst it doesn't change the way you see something in terms of, if I'm looking at an apple, my brain might think it's a pear. So it's the connecting, it's the meaning to what I'm seeing is the thing that's affected by the frontal lobes, occipital lobes. Then we've got the temporal lobes, which are auditory processing. So if I hear a dog barking outside, I know it's a dog barking outside and not something else. And language comprehension. And then we've got our little limbic system right in the middle, which is really where most of psychiatry's disorders have their origin, such as depression and schizophrenia and many of other things, because that's where we form and process emotions, and they form and organise memories, and sleeping and eating is regulated there as well. Now, as I said, all these brain lobes have millions of connections between each other. So it's really quite extraordinary that we actually function at all with the complexity of the neuronal network that we have. And these neurons change with the environment and they modulate. So, if I've stood on a bull ant and I've burnt my toe stings, I'll remember the next time I say bull ant in 10 or 20 years' time not to step on it. And that's what the brain has. It's not only just realised that I've got a noxious stimulus from the bull ant, it has then changed the neurons to record that if I see a bull ant again in 20 years, I'll know it'll sting me. So the brain has changed itself in response to that bull ant sting. Now you can imagine how many of these events happen every single minute of our lives, and the brain adapts and changes accordingly. So it's a very fluid organ, and we don't know so much about it, but we know a whole lot more than we knew 10 years ago. And then we've got the hippocampus where the memories are stored, and that's all still part of the temporal lobe, but that's where we actually lay down our memories. So when you hear a song, the temporal lobes, it's the melody, parietal lobes are the lyrics, frontal lobes are the lyrics, limbic region is the emotion, the memories it evokes, cerebellum coordinates it for yourself so it doesn't sound static, and then you can hear it again and sing along. Why I'm labouring on this area is because the way we make diagnoses in presenting features of dementia, and both in young and old, is we need to know what these lobes do, because depending on which part of the lobe is affected by which pathology process, we will present differently, and that's why the diagnosis is missed. So I know the audience is mixed, and I'm sure some people have never been taught how to read MRI scans, and some people know them backwards, and others just need a refresher. The reason I'm going to put some scans up is because we always get radiologist reports from our MRI that say normal for age, atrophy consistent with age, no acute findings. And I always have to see the films because I couldn't understand why they weren't reporting all these things that were obvious to me. So I spoke to some radiologists and they said part of the problem with radiology is that they shouldn't be over-diagnosing. And because of the correlation between radiological findings and pathology is not good, so some people can have marked atrophy and no cognitive problems, and other people can have quite marked cognitive problems and no atrophy. They don't report it. But what we do know now is specific parts of the brain that have atrophy do help us with diagnostic specification. What we do with MRI scans, so for the people that do know, we slice the head up basically in little millimetre slices three ways. So we slice it across here like that, all the way down, which are called the axial scans. We slice it all the way along like this, which is called the coronal scans, and we slice it all the way along like that, which are the sagittal scans. So we need to look at the different ones. So this is an axial scan of a normal brain. What we particularly see here is the bottom bit of the temporal lobe. So that's sort of cut through about there. If you get a big slice of a guillotine and cut me through. So what we see there quite well is the temporal lobes, because otherwise they get covered by the brain later on, because they sit low down in your brain down there. And so we see what's going on there. And temporal lobes are very much involved in dementia. So we need to see what that looks like. That's a normal one. We have the sagittal scan, which is the side on like this. So we get to see the frontal lobe, which is quite large, as you can see. And we get to see the cerebellum, the occipital lobe, the parietal lobe. But we don't really see the temporal lobes terribly well. And we see the coronal, and that's cutting like this. So we see the temporal lobes coming in on us like that. And we see them then chopped in half, and they're very good. And that's the basal ganglia, where you have some problems with Parkinson's disease. And in here, you have these little things called the hippocampi, which is where the emotions and all the memory and things come from. So as you can see, we've got, actually, if we can look at specific signs of atrophy, we can actually look at the films. Now, I mean, I've seen some horribly abnormal MRI scans which have been reported as normal, and when I ring the radiologist, I said, but what about the Sylvian fissures, what about this? Oh yeah, that's right, but I mean, we didn't have a clinical picture. And I said, you haven't done coronal views. Now, coronal views are very important to look at the temporal lobes and the hippocampi, which is where a lot of dementia stuff is going on. And they go, well, unless you ask for it, unless you say you're trying to investigate cognitive impairment, we don't do it routinely, because we're looking for strokes, we're looking for brain tumours, those sorts of things. So you have to actually ask on the request form that you're looking for hippocampal atrophy, you're looking for lobar atrophy, you're looking for any investigations of cognitive impairment, or you don't get the films that you ask for. And you certainly don't get the report that you need unless you ring them and you say, well, what about this? They go, oh yeah, it's there, but it's, you know, it's not beyond the realms of normal, so we haven't reported it. So that's why I'm always hassling everybody to show me the films. That's the reason I probably put this up, apart from as a learning exercise, because so many people misdiagnose people based on the fact that the MRI is normal. Okay, so then we go down to some typical presenting symptoms of younger onset dementia. And Vicki's, I think, demonstrated most of these very well. The slow processing of information, decline in your reasoning, abstractions, so to be able to understand proverbs and humour, judgment, mental flexibility, difficulty understanding without examples or demonstrations, shifting to different topics particularly quickly, behaviour and personality changes, memory problems and movement disorders, so that's like tremors, dyskinesias, and all that, which are more common in the younger onset dementias than the older ones. So this is a gentleman who actually was a gardener, but that's not him. That's a clip art picture of a gardener, because I thought I'd try and make it a little bit more visual, that I looked after. I first met him about 8 years ago. 46-year-old gentleman with two sons, aged 14 and 16, who's a self-employed gardener, and he's married with his wife who works public service. His mother died of dementia at the age of 52. Now, he came to me with symptoms of apathy. He was forgetful with his accounts, and he was issuing accounts in his business, so the family finances were going backwards. He would miss routine mowing jobs that he had, neglected the house chores, would get lost around familiar roads, had troubles finding the words and substituted words that he wanted to use, with a progressive decline in memory. He had terrible family disharmony, because whoever's had adolescents here know how difficult they are. Well, they're very difficult when you haven't got any ability to be flexible, accept humour, sarcasm. And he had a son who had Asperger's, which made it harder. And his son was, the room was a pigsty, as most adolescents' rooms are, and my patient kept screaming at him to clean up his room, but he just didn't know when to stop. And I got to the point that the son had a knife under the bed, under the pillow, ready to get at his father the next time he hassled him about his room. So for the first time in my career, I had actually had to refer the children to an adolescent psychiatrist, and the gentleman was referred to me, even though I see people over 65 generally. And he was the first person that I diagnosed dementia in that was younger than myself at the time. And it's a very different kettle of fish to somebody who's 80 or 85. I mean, this family had terrible financial problems, but they didn't know that they actually had a TPD clause in their superannuation. So if he had a total and permanent disability, they would pay out early. And they had actually income protection, which they didn't realise they could use. So there are all these things that you need to think that people have, because they're still in a part of their life that they have a mortgage, they have children, they have expenses, they think they're going to work till 65 and then this happens and everything goes bleh. And so it's a very different, bigger effect on the family, I think, in the younger age than in the older age, although it always affects the family. So this man, after lots of the testing, showed that he had Alzheimer's disease. So he had impaired memory and new learning, difficulty focusing and shifting attention, had problems particularly with language, word finding, reading, writing, fluency, comprehension, and he was disoriented, couldn't sequence, had problems with map, craft work and making things. So if you think back to my brain picture, that really shows many of the lobes of the brain affected, but in fact it's the connections between them that are largely affected. Now, in the younger onset, the genetics of dementia are extremely complex, and as easy as this slide is, it's not easy, and I still have trouble with it. People with dementia over the age of 75, it's probably not inherited at all. Okay, it's an age thing. The biggest risk factor for dementia is age, the older age. In the younger onset dementias, there is genetics that can be involved, but not like Huntington's chorea where 50% of your offspring have it. The disease, it's nothing like that. So you have the presenilin gene, which is a familial Alzheimer's disease, and in this disorder it usually starts, like, you can get 25-year-olds with it, and there's usually at least two family members, and often across generations, that started to get memory problems at a young age. Now, they're only about a fifth of all the people with young onset dementia, and it's really very family, but it's family, you can see it, but it's quite rare. So it's not common. What we see more commonly is the next one, which is the presenilin 2 gene, which hits the 45 to 84-year-olds. Now, this is just for Alzheimer's, not for any of the other disorders, and the amyloid precursor protein gene. And they can come together and cause an onset of Alzheimer's disease in the mid-range, but there's often not a strong family picture. Perhaps a distant relative or an older relative may have got dementia in their 80s, but I mean 25% of people have that anyway. So it's not as closely genetic. And then of course you've got your sporadic cases, which can occur in many different Huntington's chorea. There are other genetic disorders that can have sporadic cases, and people have inherited some risk factors, and then those risk factors get their expression as people are older. And that's a really simple picture of the genetics, okay? So it's very complex. It's not like autosomal dominant or anything that you might have heard about in your training. So when we look at a brain, a healthy brain, that's slice again, the ravaged area in Alzheimer's is usually in the temporal lobe and in the hippocampus, which is all to do with the things that we just talked about that my patient was suffering with. So the memory, word generation, the shifting of the topics, because the temporal lobe is very strongly connected to the frontal lobe, and there's lots of connections because the frontal lobe has the working memory and the temporal lobe stores the memory. So you can imagine the connections are massive. So if you then look at an MRI, and this is the coronal section I was talking about, these are fat, plump, juicy hippocampi, and that's what we'd like to see if we've got somebody who's probably not got Alzheimer's disease. But with someone with Alzheimer's disease, you start seeing some erosion in the hippocampi. Now, you only see that in the coronal views, so they don't routinely do those, so you need to ask for those. And this thing here is called the Sylvian fissure, and it's just on top of the temporal lobe, and you start seeing in Alzheimer's, you see some widening of the Sylvian fissures. So that's a fairly typical picture of an MRI, which is why I'm so particular. I just don't want to know if there's no atrophy. I'm looking at quite specific areas of the brain. Last year I saw this 59-year-old barrister who was always in excellent health, wife with 2 children at university. He had increasing apathy and reduced verbal output for over 2 years and sat in his barrister's chambers without getting one brief. How barristers get their work is solicitors refer to them, and if they don't get referrals, they don't get work. We don't know why this gentleman wasn't getting work because there was no mention of any problems in court cases, but probably word got around quite quickly that his verbal fluency was affecting his ability in court. I mean, it's the cruelest thing for a barrister to lose their verbal fluency because their entire life is, they win and lose cases on their word, their spoken word. So he sat there for 2 years until they nearly went broke and had to sell the house and moved up the coast. Now, he used to be a dominant, controlling, narcissistic, unpleasant man who his wife didn't really like living with, but he went to being very passive and dependent on her. So she actually found that lovely and didn't get carer stress. But usually what happens in this form of dementia is you get the other and you get a lot of behavioural problems, which we'll go on to. He became depressed because of the changes in his life, as often occurs. They had a very beautiful waterfront mansion in Mossman and had to buy a small cottage up the coast. And there was no family history of dementia. He probably started getting his symptoms in his early 50s. So he was diagnosed with a behavioural variant of frontotemporal dementia, which is the old Pick's disease. And often mood and behaviour become fixed. So people get very rigid in they demand dinner on the table at 6 o'clock and they have to have breakfast at 8 and then they have to go and water the garden at 8:20. And if the routine is disturbed, a lot of anger and agitation come out. So very difficult people to live with. I have one gentleman that his wife was nearly driven to despair, and she was depressed because he was so difficult. He was totally fixated on his abdominal pain, and he couldn't sit in the car because his pain would start getting, wobbling and all this stuff, and he just wouldn't do anything. And he was around in circles all day, and I kept telling her, it will pass. It's usually only about 2 to 3 years of the illness, and now he's passive and not tormented by his thoughts. And she said, the only thing that kept me going is the fact that you said to me it will pass. And it has passed, fortunately for her and him, but the torment was terrible. People also lose empathy and emotional warmth, so they become really selfish and unfeeling. And you might say, you make me feel sad, and they just don't see it. They lose friends, have horrible work relationships, often marriages break down. Particularly I find second marriages break down more quickly than first marriages because I think they've been less of the good years together if they've been married only for 5 years or something. Apathy or lack of motivation is very common. My barrister sat in his chambers for 2 years and did nothing. Abandoning hobbies, avoiding social contact and becoming disinhibited is the usual. So they don't normally become flat and dependent. They normally become disinhibited, loss of behaviour control, impulsive, aggressive. So you see that with head injuries. It's the front part of the frontal lobes, and you see the people with motor accidents. They get very similar symptoms to those. They lose their reasoning, judgment and organisation because of the frontal lobes. Verbal fluency and spontaneous conversation goes away because of the working memory problem and the verbal fluency. And often you get change in eating patterns. So people might gorge or start or eat things that they wouldn't have eaten before, or even indeed start eating dirt and things like that. So this very regressive sort of ritual stereotype behaviour. And that's the old Pick's disease. It's not all frontal lobe dementias. Eventually, as time goes on, you get a decline in self-care and ability to perform activities of daily living, and eventually the memory goes off. And people end up sitting in a corner with hand wringing or not speaking or just saying back what you've said. And it's got a fairly rapid decline, faster than Alzheimer's disease. So what we see here is the frontal lobe, which is actually really very, sorry, this slides the wrong way around to that one because there's your cerebellum, but it's a big lobe, okay? And that's what you see in the behavioural variant of frontotemporal dementia. So atrophy of the whole frontal lobe. That's just another view of it. And you've got the atrophy there. So the whole lot of it becomes shrunk. You see how you tell atrophy. Normally brain is plumpy and thick. When you've got atrophy, you've got thin brain and more black space. And then a typical MRI then is when you look at the sagittal view, so it's this view, you see the frontal lobe just not there. And there's this cut-off line often, and that's where the frontal lobe stops and the parietal lobe starts. And it's very typical that you've got this cut-off line. So the rest of the brain looks pretty normal, but you see that. So that's why you need your sagittal views, and you need them right in the middle, because if we took a sagittal view there, we would look like we had less frontal lobe just because we're further down the skull. So you need to know exactly where it's taken in terms of the position. Next lady, again, just a clip-art picture. A 54-year-old lady, married lady, who noted at work some disorganised thoughts and word substitution, some difficulty comprehending, but still at this stage remembering to be able to do activities daily of living, like cooking, washing, those sorts of things, and memory was still relatively preserved. Now, this lady, you have this in your, I've got to read it from here. The reason I've put this up is because the condition that she suffers from, which is semantic dementia, is actually a really hard one to understand, because it's a frontal lobe problem which affects the left, or frontotemporal dementia problem, but it affects the left temporal lobe, and it's very rare. But what you do, you lose your ability to understand the meaning of words. So this particular test is one we call the Addenbrooke cognitive examination that Professor Hodges wrote up. And all that she was asked to do was to name each of the pictures. And even people with quite advanced frontotemporal dementia or Alzheimer's disease or vascular disease can do reasonably on this test. But with semantic dementia, even though she was still cooking and cleaning and everything else, she couldn't name what a spoon was. It was a thing. The book was you put it on the table. The kangaroo was Hoppy. Penguin was a lovely thing that you follow around. So it's just the meaning of words. She knew what they were, but she couldn't come out with the word. An anchor is something for the car. A camel runs around, lifts someone on his back. So the memories have come back as she knows it's a camel, but she can't say it's a camel. The harp is a beautiful sound, can listen to it. The rhinoceros, he runs around, he's not bad at looking at people. The barrel is lots of grog, can have something in it. The crown is a woman looks after it on high and other people watching. So you know she knows exactly what it is, but she can't actually figure it out to tell you. The crocodile, he's no good, he can bite you, he lives in water. And the piano accordion, that's great, need two hands, it's lovely, many people like it. Now this was only a few months ago that I got this referral, but it was probably the most classic semantic dementia referral result that I'd ever seen, and that's why I thought I'd share it with you, even though it's small writing and everything, because it really makes you understand what semantic dementia is. Semantic dementia is one form of what we call progressive aphasia. Now, this is another type of frontal lobe dementia, and this is where it's going to get a bit technical for some people. The old Pick's disease was at the front of the frontal lobe. There are two sorts of frontal lobe dementia that predominantly affect the temporal lobes, and one of them is semantic dementia. So you lose your memory for words, impaired comprehension and meaning, presents as a decline in language abilities, but numerical abilities, memory, navigation, skills, eye-hand coordination remain intact until later, but there are some subtle personality changes. And then you've got one that affects a different part of the temporal lobe, and it's called progressive nonfluent aphasia, which is difficulty with word production, distorted speech, wrong words, grammatical errors. So they have really a lot of difficulties early on actually speaking to you. And I've seen some people that can't speak to you at all and have absolutely no verbal output that completely understand everything you say. And that can be actually very difficult because these people don't say anything, and so they're put into, and they're calling out in other ways like behaviours, and they're put in dementia-specific units, and they're treated as if they've got sort of really advanced confusional state, and they have none of that. And I said, you think people are treating you like an idiot, don't you? And they go, yeah. And they not only say how many fingers and all this, and they completely understand. They just have no speech. And of course that causes incredible depression in these people. And it's just a matter of explaining to people that they understand everything that you're saying, and it just changes the way management occurs. Changes in behaviour are uncommon, but do occur at times, and some develop apraxia, which is movement problems. And then later on you get some organisational problems, and you get more of the whole frontal lobe affected rather than just the left temporal lobe, because the frontotemporal dementia is both frontal and temporal. So here we've got our coronal section, and we've got the right temporal lobe's looking pretty healthy, and the left temporal lobe's not really there. And that's what you get in semantic dementia. But in progressive nonfluent aphasia, it hits higher up in the Sylvian fissure. So the bottom, the temporal lobes are right, and that's the Sylvian fissure. Now, whilst these illnesses are rare and whilst they're untreatable, the management of them is hugely different to someone who's got advanced dementia, advanced Alzheimer's disease and can't speak, because these people understand everything. And so it's really demeaning to them to be treated like they have no comprehension. And they're young, and they often end up in a nursing home with a whole lot of 80 and 90-year-olds, and they get really angry and bewildered, and then of course they get filled up with medications, and so it goes. And all you need to do is educate people that these people understand but can't respond verbally, and they settle right down. So whilst I might be labouring on small issues, the management of people like this is just so different, and so different without having to use medication, and the quality of life that you can give them if you figure out that's what's going on with them is incredible, because these people can live for 10, 15, 20 years trapped in this brain that doesn't talk. So it's rare, but it's worth remembering, because the benefit to families and everything, I mean, they can't write either, so you just have to sort of nod and give them the, do you mean black or do you mean white? And they nod and they'll tell you, because they understand everything. And makes everybody's life a lot easier if you can get that. But a lot of people don't get it, and that's the trouble. Next gentleman, 55-year-old married man, ex-smoker, high cholesterol. His father and uncle both died with a stroke at 48 and 50, so we're looking at familial pattern. And his problems started with concentration difficulties at work with loss of sales. He was a salesman. He had an episode of confusion which resolved, but after that his memory was worse, and he had a stepwise deterioration over several years until he was unable to work. He afterwards got secondary depression and was a high suicide risk as his insight was retained. And that is a fairly typical picture of vascular dementia, that there's a stepwise deterioration, so there's a period that things are plateaued and then it goes down. There might be a mini stroke, and then there's a plateau again of cognition, and then down again. And the insight, as you saw Vicki has, is very, very sad for everybody, because the patient is aware of their deficits, whereas in Alzheimer's disease, people are often not as aware. And it's just a very sad thing to experience. So I understand the impact that it's having on you and your families and everyone around you. And people sometimes just don't know what to say, so that's why they don't say anything. It's not that they're being cruel, they just don't know what to say. So we have this gentleman made a couple of serious suicide attempts. Now, his risk factors were some of the usual risk factors for vascular disease, but he also had a family history. And in younger people, kidney failure, amphetamine and cocaine use and lupus can also cause vascular dementia. So any sort of vasculitis of the brain can cause vascular dementia. There's lots of causes. And in younger people, it's more commonly related to stroke risk factors, but also then the vasculitis and those sorts of things. Now, vascular dementia is a risk factor for Alzheimer's disease, so sometimes the two can coexist at different levels, different severities as well. There's another rare as rocking horse manure who called Catasil, and this is a cerebral artery. This is the really hard one that no one ever remembers, including neurologists. Cerebral arteriopathy, autosomal dominant with subcortical infarcts and leukoencephalopathy. It's a familial disease of the brain arteries that starts in early life. It's related to chromosome 19, and it causes really extensive white matter lesions. And people present with they can present with ataxia, they can have infarcts, they can have migraine, and eventually it leads to dementia and some motor disability. The diagnosis can be made by skin biopsy. This gentleman had 2 children. The one that I haven't got his vignette, and I said, look, you've got to go and get yourself tested, because there was such a strong family history of stroke and people dying in their 40s from it. And the brain scan is not that different to a brain scan with vascular dementia. So you get, in vascular dementia, you get sort of stroke areas and white matter changes. In CADASIL, it's just everywhere. You just have these marked scar tissue in the white matter. And then you get some brain shrinkage as well, but mainly it's the white matter change. It's common in people in their 80s to have some, what we call, the radiologists call periventricular white matter ischemia, but when the ischemia is in a young person, or when it goes beyond the periventricular area, which is the close area here, it's more for the doctors in the room, and extends further into the brain, it's probably abnormal. Whereas periventricular white matter ischemia in older people, I think I probably have some already. Nearly everybody has periventricular white matter ischemia. But if it goes out further into the grey matter, or it happens in a younger person, it's probably got some sort of pathological. My secretary recently, she had a brother who died at 38 from a heart attack, and she was starting to get some concerns with her memory and concentration, and she's 40 and had an MRI, and she has lots of white matter change already, and she was worried that there must be something familial. As it's turned out, she's got Lyme disease, so she has a treatable condition. But yeah, the white matter changes shouldn't be occurring in 40-year-olds. Then we've got Parkinson's disease, which in some people can cause dementia, only 20 to 40%. And you have the usual motor symptoms, so the tremor, the slowness of gait, the shuffling, the difficulties initiating movement. But the same sort of things happen with cognitive symptoms, so you get mental slowness, mental flexibility, prioritising and goal setting, and difficulty with social cues. It was interesting, I went to a neuropsychiatrist meeting last night, and one of the neurologists said we probably have three motor systems. We have the pyramidal, which is our legs moving and everything. We have the extrapyramidal, which is sort of our balance and organisation. And he thinks there's probably an emotional motor cortex as well. So people that have emotional discontrol, they end up with this cognitive problems, but they're probably part of the Parkinson's disease, which is what they believe now is the third motor system. Now, I'd never heard that till last night, but you can see that because you see people that have got really quite marked angst emotionally that often get stiff and rigid and those sorts of things. So that's probably what the Parkinson's, the mild cognitive symptoms are. If you get the Parkinson's dementia, it's a much more pronounced cognitive impairment, and that's another one that deposits tau proteins rather than amyloid. So it's related to Lewy body dementia. And you can get visual hallucinations in Parkinson's dementia, and you get them in Lewy body dementia. Visual hallucinations are uncommon, except in delirium, if we're not psychotic, or if we're not schizophrenic, and they usually mean delirium or Lewy body dementia or Parkinson's dementia. Psychiatric symptoms in Parkinson's disease are common because of, firstly, depression is very common because they can't do the things they used to do and they retain their insight. There's some repetitive behaviours which are probably related to the dopa drugs that they're on, so they can have quite disturbed impulse control, excessive shopping, hypersexuality, binge eating, gambling, like the ones with the frontal lobes. Last night there were a few people presented, and in fact one lady was doing line dancing 7 days a week, and it was wondering whether that was the L-DOPA or whether she always loved line dancing, but it got to the point that she then started meeting men at line dancing and being hypersexual, and it was related to dopamine medication, and her marriage broke down and her children wouldn't speak to her, and she was in her 40s and she had Parkinson's disease. So, I mean, that's a sort of tragedy that can occur in addition to the tragedy of the motor symptoms already, or the emotional and disturbed impulse control problems of Parkinson's disease. And this is all often in young people. And then we've got the other dementias, such as dementia with Lewy bodies, which we talked about, which was with the visual hallucinations, often fluctuating cognitive function, early incontinence, movement problems come later, and prone to unstable blood pressure and falls. Now, Lewy body is more commonly in older person's dementia, but it can happen in younger. We're going to have a whole range of baby boomers coming through with HIV-related dementia in the next little while because they're all sort of coming into the right age group, and that's got a different presentation as well. And alcohol-related brain injury is actually much more common, you realise, even in the very old, let alone the middle age. You know, there are a lot of people that drink a lot of alcohol and you don't know about it. I probably said it last year, but the people that weren't there, I had a lady I looked at once, she wasn't older, she was older, she was in her 70s and about 5'4" and the sweetest little thing, and it had memory problems. She had a memory clinic, and I asked her what she drank, and she said she drinks fruity Lexia. And when I actually asked her husband, was it bottle or cask, because cask wine is really dangerous because you don't know how much you've had, he was buying 4 litres of fruity Lexia a day, and she was drinking it. And she didn't know she was having that much because she couldn't remember whether she'd had any alcohol or not. And the cask, you don't see the level going down. So it's very difficult for people who suffer with memory problems to estimate their alcohol use. I couldn't swallow 1 glass of fruity Lexia from a cask, but no, 4 litres a day. That's the worst I've seen. But there are, that's obviously so toxic on the brain. But there are people that regularly have a bottle of whiskey a night, and you think, how do you do that? But they've been doing it, and they have alcohol-related brain damage, which if they stop drinking, will stop progressing. Unfortunately, a lot of people that drink alcohol smoke cigarettes as well, and then they get the vascular problems. Then there's a whole host of rare neurological disorders, and again, this is going to be more for the doctors in the audience. Huntington's disease, which is a rare genetic disorder, has involuntary movements, personality change and cognitive impairment, and symptoms start 30 to 50. They have often a frontal lobe type of dementia. You can get sporadic cases of Huntington's, so you don't need to have it in the family to get it. So it's worth remembering. There's corticobasal degeneration, which is where the basal ganglia degenerate. Steele-Richardson syndrome, which is one where people can't look up like that. Their eyes have this supranuclear palsy. They also get a frontal lobe type of dementia. Motor neurone disease can get a frontal lobe type of dementia. The Down syndrome, as I talked about, that's usually Alzheimer's disease. And multiple sclerosis can present with cognitive deficits. So these are all typically neurological degenerative disorders that start occurring in the 40s and 50s. They tend not to be late onset, but they can present with Huntington's disease. One lady that I'll try and illustrate what Huntington's disease can do. She was actually an older lady. She was in her mid-70s and the mother of someone that worked at ACAT. And she started getting these abnormal movements of her mouth. So she was doing this and sometimes her hand went like that, but not very much. And she went to see a professor of neurology who told her that she had senile chorea and not benign senile chorea, not to worry about it, did all the tests. Anyway, the ACAT nurse came back to me and said, Mum's different. She's not the mum I knew. And my brothers are really angry with me because they think I'm trying to label Mum, but she's not the mum I knew. She's not able to understand humour and sarcasm. When we did some cognitive testing, she did have frontal lobe symptoms of cognitive problems. So I did genetic testing and she had a sporadic mutation of Huntington's chorea, which was relief to the daughter because she knew something wasn't right with Mum, but catastrophic for the family because now everyone was at risk factors of having the Huntington's gene, anyone below this lady. So all her children, the grandchildren and everybody else. So there can be sporadic mutations. And, it took me sitting with some cognitive testing rather than neurologists with all the MRIs to figure out there was something not right with her cognition, which is why I ordered genetic testing. I've only done it twice and both times it was positive. So you can get sporadic Huntington's. So the impact of dementia, that was said for me before I started speaking today, on everybody. And I couldn't do it justice explaining the way you've explained it tonight. You have got some specific groups that have some greater difficulties with it, and one of it is the culturally and linguistically diverse group, because some of the cognitive testing tools that we use are not for people who have English as their second language. Aboriginal and Torres Strait Islanders just don't have the access to services, and some of the mystical thinking and all that they present with can be seen as cultural by people that are non-Aboriginal rather than actually something that equals illness. Fellow staff members of people that are suffering with dementia that don't understand because someone's young and they look fine, so why are they being bitchy at work or all those sorts of things? This often can be before they've been diagnosed. And everyone else we've heard about earlier. This was a person with young onset dementia. And it was a quote. So I lost everything that defined me as a productive and meaningful man when I had to stop working because of my symptoms. The whole role in life shifted from being the main breadwinner to now being Mr. Mum. And we've heard other examples of very similar experiences. This is an incredibly busy slide, and I can't see it, so I can see it if I turn around from you, but it's in your handout. The main reason I put it up is that it's a bit of a checklist to try and help you to work out what sort of dementia somebody may be suffering. So that some of the Alzheimer's disease, for instance, gets memory problems very early, whereas many of the frontal disorders don't have memory problems until later. So if I've got someone with some cognitive problems but no memory, I'll start thinking maybe they're one of the frontal lobe problems. And I won't go through all of them because you can see them all, but as you see, things like Huntington's, Parkinson's, frontotemporal don't have a lot of memory problems early on. Retrieval, yes, but storage, no. And that is something that I use every day in my memory assessment checks if I see someone's got some memory problems, and why we do the cognitive testing. So we look at the pattern of the cognitive problems. Mini mental state examination doesn't test frontal lobe function, so it's pretty useless for younger onset dementias, but or frontal lobe dementias, younger or older, but often the younger onset dementias are the frontal lobe ones. So we do the addenbrooke cognitive examination, which is the things that Liz has done for many of the people when we refer to the memory program, and that looks at all areas of cognition: writing, speech, recognition, language, planning, frontal lobes, functioning with verbal fluency, I'm tired. Set shifting, and there's also a like Peter. Is that right? So shifting from one to the other can be difficult, and that helps get. I can virtually tell from the cognitive, the Addenbrookes, what I'm probably going to be looking for, and so we're using much less neuropsych testing than before. And Professor Hodges designed that form. This is just a bigger version of similar but less technical words for people that are less technically inclined. So word understanding, emotion, and you've got the same diagnoses again, and this is a bad colour on a slide, but again, you've got problem solving, word production, behaviour, emotion, movement, and I can't even see what the purple one is. It says spatial numbers, I think. You've got it there again, but it's another thing that helps with the diagnosis. And also, this slide then helps people who are staff members, carers, family members understand the effect on people's brain function. So if you know that someone is having problems with word understanding, such as they've got semantic dementia, you communicate with them differently. Like I said to you, rather than just assuming they don't understand, you communicate in a different way, and the quality of their life and everyone around them goes up hugely. And if you understand that somebody who's got behavioural variant of frontotemporal dementia has got terrible emotional problems, like my lady that I kept reassuring it will pass, it kept her sane, just coping with that stage of her illness, because dementia is generally a progressive illness, and different stages of the illness have different presenting symptoms. So as you can see with Alzheimer's disease, memory is quite early, but some of the behaviours come on later. Psychosis and things are quite early, but some of the behaviours later. And they do change, and everyone is different. So there is no... I've seen people with frontotemporal dementia that have gone on for 30 years and have hardly deteriorated at all, and that's been shown out in John Hodges' papers, and it probably, he thinks, is related to the Asperger's spectrum disorder, but that's not been proven. And then you've got other people that, 1 or 2 years the dementia can take them. So everybody's got a different course and a different level of decline. So people always ask me, how long have I got, or how long till I can't function anymore? And I suggest to people that if you think about how you've changed in the last 12 months, that's probably about as much as you're going to change in the coming 12 months. So with things like Suvinade, we're hoping to give the brain the nutritional substance it needs so there isn't the decline. And with people with vascular dementia, we make sure that they don't have abnormal blood sugars or cholesterol. So we really treat people with all these different illnesses very assertively so that we don't... Having the illness doesn't mean you're necessarily going to decline at the average rate of speed that everybody says in the books. And I think that's very important, because there is no single answer in terms of the course that someone's going to go along. And people change over time, and you need to adapt to that. So that slide from last time, we'll talk then to communication strategies. So again, you've got this in your kit, and it's something you might just want to keep by your side. And we give it, to family members, to staff members in nursing homes, to people just doing assessments. So if someone's, for instance, got memory loss, they deny being given information because people think they won't remember. Their life feels empty. Arguments occur and facts blur, but don't contribute to those. And don't correct or challenge. If someone says, I already had a bath, there's no point if you tell somebody 30, 50 times you haven't had one. It won't work. You change the subject and divert around it. You have a lot less tension. And people, that's what the Living with Memory Loss programs teaches people. Because if you try and go on head on with everybody, it just is bad for everybody. So this is also in your kit, and you can keep it on the side of your desk because it is very useful in terms of when we're talking. So I've got someone that has obviously got some problems shifting cognitive sets. I speak a lot slower. I don't go to the next thing quickly because they're not going to get it. And then that helps reduce the anxiety and angst and stress, which is illness does on everybody. And that's what we can do now. We haven't got a cure, but we're looking for prevention strategies, delaying the speed of decline, making the quality of life. And there are many people in this world that have dementia that have a very good quality of life. But we need to be able to make sure their environment and their situation is good. And I'm sure, as you say, there have been some positives. Your relationship together has been different. And obviously, I'm sure you were always close, but you have this understanding of each other that you probably never had all your life. And that this in-tune thing, and it just changes things when you have this illness. But it doesn't have to mean doom or gloom or a horrible quality of life for people. It's just that people need to be able to change with it. So we're going to have a supper break now. And this is this chart that continues. And it's also what happens in older people when they're in nursing homes, and if someone's, as an example, wandering all the time, it's probably because they're bored, they've got nothing to do. So give them something to do, they'll stop wandering. Or if they're screaming, they're probably in pain or they're lonely. So when people lose the ability to communicate what's wrong with them because of their dementia, their behaviours often communicate what's wrong with them. So it's a matter of actually finding out what started the behaviour, what stops it, when it occurred, what are the triggers, and then they can't tell you verbally what's distressing them, but they can tell you in their behaviours. And if you can figure that out, you don't have to give people medication to bomb them out. It's just a matter of working out what's going on. Like my lady in the nursing home, that everybody thought she should be in the highest dementia wing because she was trying to get out and on the doors. She just couldn't speak. She could completely understand. She's now in the hostel section, and people are communicating with her. That's been a huge improvement to her quality of life. She was on antidepressants and antipsychotics. She's not on any of that now. And she's still got her illness, but she's got a quality of life. And I think that's what you need to try and emphasise when you're caring and when you're suffering with someone with dementia. So we're going to delay the questions now till after supper, but if anybody has a case vignette they'd like to share, because younger onset dementia is still rare, it's less than 1% of all dementias, so you won't see it commonly, but when you do see it, it's often masked and presents with depression, anxiety, those sorts of things. So I see in my practice probably 50% of my people have younger onset dementia because I'm a psychiatrist, and that's where they often end up, where in fact that's not what they've got. So I'll close there. I just say, does anyone have any other interesting vignettes that they'd like to share with us? Dr Kossoff, you were just saying you had someone at 34, first diagnosed.
Dr Kossoff, I work at John Flynn and Rowena and all that. I thought you worked locally, but you're from Sydney, so welcome. I had a question for you, actually, before I talk about my 34-year-old or whatever. What do you do? What do you do with, say, a 45-year-old working executive, bank manager, whatever, and this is sort of a vignette, and they make an appointment to see you. They convince the GP that I've got problems. They come and see you, and they have done a lot of reading on younger onset dementia because it is so readily available. And they know they've done a little bit on frontotemporal, and they've they know about hippocampi, and this is a real case who came to me, and they sit in front of you, and all the testing is normal. They've had scans before they came in. And so, doctor, do you think I'll get dementia? Somebody in my family had it, a distant uncle or something like that. And I'm so afraid that something's going to happen. What do you do there? Put you on the spot.
Oh, that's okay. Sorry, I didn't mean to put you on the spot. I think it's common. I think people come to people like me expecting that they're going to be told that they've got dementia. It's common. People just dread it. It's the biggest fear that people are going to have dementia. And you don't have to say to someone if you think they've got it. They know. And that's what I've found in the last sort of 5 to 10 years. The level of information amongst the community is much higher. And so they already know they're coming to be told whether they've got the diagnosis or not. Someone like that, I would have thought they're sort of obsessive compulsive disorder type symptoms, and people with obsessive compulsive disorder do get cognitive symptoms. They get some concentration, some difficulty shifting sets, get caught up in things, and so they look like they have some memory lapses. And I would be first questioning if that person actually had some psychological problems, and ask them why were they here, and why were they concerned about this, and get them to do a whole lot more talking, because that's what we psychiatrists are good at doing, is getting people to talk without saying too much at the beginning, and let me try and make a diagnosis and think that they've probably got depression, anxiety, obsessive compulsive disorder, and they're focusing on this concern that they might get this down the track. Then I would say, if that's what I think you've got, I'd tell them and treat that and say, look, there are no indicators that you have any risk factors to get this disorder at the moment, but I think some of your cognitive symptoms are relating to having whatever else, and we should treat that first. Because I would think that that's probably what would be going on. I don't think you can predict, if there isn't a strong family history, who's going to get something further way down the track. But if there was that degree of concern in that young person, who's a bank manager, so by definition they're very organised, obsessional people, I'd question whether that was actually the hidden diagnosis. That's the psychiatrist's answer. Because we look at, like I teach all my registrars, when we interview people, we don't have, we have X-rays now and MRIs, which is great, but we didn't have those for a long time. All we had was our eyes and ears. So when I do a psychiatric interview, people just think I'm having a chat. All my medical students think I'm just being so nice and having a chat with everybody. And then they leave the room and I go, well, what did they have? What was their mental state? And particularly if someone's paranoid or difficult, they can't think of anything. And then I say, well, didn't you see the cigarette stained fingers and all these usual things that we've been taught to say? And I said, couldn't you see that the daughter was frontal, she's got epilepsy, but the mother's got frontal? That's just to registrars as well. How did you get all that from a chat? And I say, because you're not just a participant in the interview, you're an observer. So what people don't tell me is probably more important than what people do tell me. And then after I've let people go on for 20 minutes, half an hour, then I ask the questions to try and zero in on my hypothesis of what's going on. And that's what I think would be happening in someone like that.
So thank you all for making the effort to come tonight. Much appreciated. And we look forward to seeing you all again at our next education event. Thank you.